Welcome to episode 4 of the 5% podcast. I'm your host, Dr. Corey Harris. Today I have on with me Dr. Aimee, who's a physical therapist and occupational therapist. Now, Aimee, I know you're pretty busy. You're an entrepreneur. You're a dual professional therapist. You're a wife. Let's go ahead and get started today. So tell us a little bit about where you're from and where you went to undergrad.
So I am from Maryland. Where I went to undergrad was University of Maryland, Eastern Shore. I actually wanted to go to Hampton, but I had a scholarship for University of Maryland, Eastern Shore. And of course, my parents were supportive of going to a school where I had, the financial support. So that's where I ended up going. I majored in rehabilitation services. When I first started off school, actually, I started off as a biology major because I was between becoming a therapist and becoming a physician. One of the reasons why I ended up going into therapy was I had a sibling that had a pretty severe car accident. He basically, he would have died in the car accident. It was pretty bad. He was hit by a Mack truck. So his car was crushed. His hand had to be reattached. Pretty much anything on the left side of his body was fractured. So his femur was fractured. His foot was fractured. His hip was dislocated. You name it, he had an injury, and he was a left-handed person. So when he was going through his therapy, I was about 13. So I used to go with him to his sessions some of the time. He was seeing an occupational and a physical therapist. He had to see an OT for his hand that had to be reattached. There was a fellow from Curtis Hand Center that did the procedure, which is where I decided to do one of my internships. So it became full circle after I went to school. So he had to learn to walk again. He had to be able to, learn how to use his hand again. And it was a pretty extensive process. So that's what was kind of pushing me toward the direction of possibly going into therapy, because I felt like I've had a more integral role in that person's function. And I got to spend more time with that person. If that's the thing that I decided to do. So I started off school my first year as a bio major, pre-med, but then I solidified my choice to become a therapist, and I ended up switching it to rehab services, which is a little more, I'm gonna say OT-ish, because it had some remnants of counseling in it. So it wasn't just allied health, it was also behavioral health mixture. The task that I had to do when I was about a sophomore in school, I finished school a little early. I graduated when I was a junior. So when I had to do one of my final projects for school, we had to do kind of like a resource book. And the other project was a list of goals. So you had to pull up, what you wanted to do for your career. If you were moving forward into grad school, what schools were you choosing? What's your backup plan if you weren't to get into school for your primary desire. So there's a lot of things that we did. Like if you went the rehab counseling route, you did a lot of like work strategies for people. So you kind of had to do it on yourself for your final project. So when I was doing that project, I was kind of conflicted about PT versus OT because I had exposure to both when I was watching my brother. So when I was researching schools, I found University of St. Augustine. So I saw that they had a double major, and me being an overachiever that I am, I decided to go that route. My father and mother took me to the school. I don't remember if it was when I graduated or around that same time, like during a break when I was in school. I feel like they took me when I was on a break in school. So I met Dr. Paris in the hallway, and he introduced himself. He was extremely personable, told me about the school. We toured the university, and I decided that was going to be the place that I wanted to go. I knew it was a smaller school. And I felt like, based upon the information I was, getting from it, that it was going to be a good program. I also researched it a little more. I started looking on Facebook for people that were attending the school. And that's how I found Rashad. Rashad was already at school. So I asked him some questions about the school and, tell him that I was interested, and I was, finishing my undergrad, and I was looking into schools, and I don't know why I chose him, like out of the people on the list, but I just got kind of like gravitated to his profile. He actually answered. So I ended up going to that school. I got in. I only applied to one school. That's the school I got into. And it was my top choice. So I didn't even bother applying to any other one. And that's the story of that.
All right. Now, that project that you said you did in order to research schools, lay out your plan, what's your backup, that's something we didn't do, but it sounds like it's something that all programs, all students should be doing, which sounds pretty cool, though. Right. And similar to what you did reaching out to Rashad, I did the same thing with Cece and looking at St. Augustine, looked at the list of people in the program online on Facebook, and I randomly reached out to her and asked her questions about the school as well.
That's pretty funny.
It took her a while to respond, though. She might have thought I was flirting or hitting on her, but she responded, told me about it. Then I kind of made my plans to go there from there. Looking into both OT and PT, which I was interested in both programs as well. But talking to people in the field, I kept hearing that you'll get stuck in one versus the other, so it didn't benefit you to major in both. What was your thoughts on that?
So, currently living it now, being both disciplines. There's pros and cons to it. I usually have to negotiate my salary with every job that I go to. It does have a benefit because I usually can find a job pretty easily. So say I can't find a PT job in the area that I'm going to, I can look over on the OT side and sometimes find work. So when I was a travel/contract therapist a lot of my career. So I would switch between disciplines from one to the other. Like say I was working nursing home, it would be to my benefit then, because say they were low on the census on OT, we'll cut contract staff first. Because I could slide on one side or the other in terms of being able to maintain work. So it has had its benefits. My salary is usually a little bit higher than somebody that just had one or the other because I always negotiated. In my current role now, I'm a manager. The role as a manager is almost never open to OTs. I've noticed it's always a PT position that's open as a manager. I've never seen one that said OT management. So I typically apply, of course, because I'm both. And then I create an OT job within it. So where I am now, I used to work for them in the past. Long story. When I got married, I left their business and I became a travel/contract therapist for a little while. And then when me and my husband found a home, I needed to find another job. In the last place that I was in, I was contracting for the same company and they wanted me to come back and take a full-time job as a manager in the area I was moving to. So I went ahead and I did that. Before leaving the company the first time, I actually created OT at 2 of the locations that I was working in. So I was doing hands, ortho, lymphedema as a PT and OT. So I was kind of like a 2-for-1 in both clinics. Currently, there's somebody that's still working there now that's OT that splits locations. So I think it's a benefit because I usually am creating an opportunity for somebody else, even if it's not for myself. No. Where I am now, I treat some pediatric, I treat neurological, I treat ortho patients. So I enjoy the variety because I never really went into the profession with like, I just want to treat sports ortho or, I want to work with people with strokes or I just want to work with kids. I kind of always had the mentality that I wanted to do a little bit of everything. And I've done that the entire time I've worked. So it's opened a lot of doors in that regard. If you're not business oriented in terms of like negotiating your salary or finding ways to make extra streams of income, you probably won't feel a benefit to it, in all honesty. One of the cons is you're probably going to get overworked sometimes. Because like when I did contract work, if I ever was contracted to do both, like I earned that salary. I definitely usually like saw a lot of patients or I work long hours. So, I could see either end of the spectrum in terms of, it being a benefit or not, being something you want to do.
Right. Now, I do think a lot of us do get caught in that. I just want to stick to this one particular patient population. But I do feel like being more open to different things keeps your skills sharpened.
Oh, yeah.
Why we all
Um,
just stick to that one particular patient population when there's so much out there, there's so much you can do that I think we're not educating the public on as therapists that we're missing out a lot on, and the actual patient is too.
right. And honestly, a lot of the skills that I have, they carry on. Even if I were to end up working in one environment and treating one patient population, the skills that I learned in one thing helps me with the other. So my experience in acute care, for instance, I know what that person has experienced if they're seeing me after a cabbage and they're coming to my clinic in outpatient. If it's somebody that is a general orthopedic patient that had knee replacement and they have a ton of swelling, I'm a certified lymphedema therapist. Just because they don't have lymphedema doesn't mean that that same stuff doesn't apply for somebody with edema or somebody with venous insufficiency. So I tend to get better results from my post-op patients because I address the swelling like pretty early on to help with their healing process. Complications, like if I'm seeing somebody in a general orthopedic environment, I feel like I'm more in tune to some of the complications that you might see or their drug interactions. A lot of those things are things I had to work on knowing when I was in a hospital environment or when I was in subacute care. So even if you have a specialty that like you want to only do hand therapy, having a variety in your background, it'll be an awesome tool for you, because even if I was just seeing hand patients, a lot of these patients have functional deficits, so if I haven't worked in another environment to be able to problem solve, it's going to make my job a lot harder. Right. I've worked with a lot of people that were CHTs that might have looked to me for answers for certain things because I might have had more experience being able to see some of it. So that's just my 2 cents on it. But I think it makes you more diverse as a therapist. Even if you just start off a couple of years doing a different setting than what you intended on, 9 times out of 10 is going to help you in the long run, even if you just want to do outpatient. I feel like a lot of people, especially that want to do PT, they have a tendency to want to do like outpatient ortho. Right. And sometimes when you start school, you might not even like it. Or you get into the profession and you realize, well, maybe this isn't the thing for me. Having gone to University of St. Augustine for one of the programs that I was in, they were very manual therapy based, so a lot more hands-on information in terms of the orthopedic environment. So I think having gone to that university kind of helped in terms of being intuitive with people and being personable with people, because you're putting your hands on people to do manual therapy skills. Like, you have to be personable, otherwise it's awkward. So I do think my educational background and having been able to go to a lot of different settings is something that many therapists could benefit from, even if they just want to focus on one.
I definitely agree. Now, going back to the getting into grad school, you want to do your dual degree program. How was the curriculum for that laid out? Like, would you be taking courses? Did the courses for both overlap? Would you focus on one track, then go into the other? How did that work?
So how it would normally work and how it worked for me may have been 2 different things. So I actually ended up going to more than one school, and I'll kind of explain a little bit about that. But the track for University of St. Augustine, you start off as a OT basically, but you take a few extra classes that will make you eligible to go into your PT institution at like a 3rd year level when you come back from your internships. So I might have taken an additional course like Therex 2, which a typical OT may not have to take. Manual therapy, massage type classes, musculoskeletal 1. So there were additional courses that I had to take while I was in my first few semesters. That way, when I was done with that didactic part, when I come back from internships, you start off, I believe it's your 7th term. It's either 7th or 8th. It was a lot of terms when we were in school. I think it was your 8th. I think it was your 7th term that you come back. You start off at the higher level classes that you would if you were in your 3rd year PT school, and you finish off. Very long story short, I'll probably, just give you the long and the short of it. I had some life changes that were going on when I was in therapy school, and I didn't finish the entire program. I did have my OT degree. I was licensed as an OT, but I didn't finish the entire PT part there. I ended up going to another school closer to where I'm from, to help my family, take care of my mother. And I would commute back and forth from where I ended up going was Howard. When going to Howard, I would commute on the weekends to do my mother's wound care or to help my dad around, because when I first moved back from Florida to Maryland, my mother was in a wheelchair and she wasn't doing well. So my course was a little longer than the average because University of St. Augustine, it was 3 years and a trimester. I did about 3 years. But when I moved back to the Maryland area, I basically had to start school over because a lot of the stuff, especially grad school, things don't transfer over.
Right.
So I actually worked as a therapist, OT, in the hospital setting while I was in school at the same time, because a lot of the classes transferred over and I pretty much had already taken all the curriculum in the past. So I would tutor, I would work, and just attend class until I got to the point that I was finished so that I could sit for my exam. So I had to overcome a few obstacles to get to that point, but I took the longer path to get to where I had to go, unfortunately. But at the same time, it did have its benefits. University of St. Augustine was very manual therapy, orthopedic based. Howard did have some strong suits in terms of cardiopulmonary coursework and having a little stronger background for like acute care and wound care. We didn't really have that much of it at University of St. Augustine because our semester or trimester for cardiopulm was, wasn't that like a 4-week class or a 6-week class or something like that? Versus when I went to Howard, there were 2 levels to the class. So having been to both institutions, it actually helped me a lot because I became a very strong therapist when it came to manual therapy based stuff and acute care. Putting those 2 things combined.
All right. Now, what was going through that dual degree program? Sorry. What were the support systems like? Like, did you have professors or was there student programs that helped with mental stress or just getting through the curriculum? Or was it fellow students or cohorts you leaned on?
So most of it was relying upon each other. We were assigned people when we first started school. Mm-hmm. I talked to her to an extent. She started off as a dual major, but she ended up only doing the OT portion of it. She decided she wasn't going to finish and do the PT part. So when I was back for the PT portion, I no longer had a cohort that like matched me for that regard of it. But a lot of it was interacting with other classmates to have a support system. You are assigned an advisor. I actually had 2 different advisors because when I was in my OT program, I had one person. And then when I was finishing off the PT part, I can't remember the professor's name. Is it Erica? Dr. Kiernan.
I don't remember her first name.
But she was a double, basically a long route double major herself, because she did the double major before it was even a thing, because she was a PT and then she came back to finish her OT before they had that program established. The program for double major doesn't even exist anymore because they stopped doing that, I think, a year ago, maybe 2.
I did not know that. Yeah.
There was somebody, because when I'm in Facebook groups and people see that I have both licenses, people always ask me. That's like, a icebreaker every time somebody meets me, because they always want to know, well, how did you do both? So when I mentioned the school, there was a young lady that was attending St. Augustine that told me that they stopped the program after she had gotten out of school. So I think it was about 2 years ago that they stopped doing the double major.
All right. Now, what was the matriculation through Howard's program like for you?
So Howard was different, partly because I was at a different phase in my life when I was going to school there. I'm starting off a little bit older than some of the other students. Most people are coming there having been, just getting out of undergrad, versus I was already working as a therapist, and then I'm coming back to school to finish the rest of, the remaining portion of my degree. Yeah. So honestly, a lot of it was I went to work, I went to class, I came back and tutored, like that was it. I didn't do a lot of socializing or hanging out after class because I was just at a different phase and I had other things I had to take care of. in terms of working and, you know, coming back home to check on my mom, because most weekends I wasn't even at school, you know.
How long was that commute for you?
What'd you say?
How long was that commute?
About 45 minutes to an hour.
Wow. All right. Now, what were you about to say?
No, go ahead. Go ahead.
Oh, no, I was going to ask you, what were your clinicals like? What settings did you do, both OT and PT, and what were your experiences in those?
So I had a ton of internships, because if you combine both programs together, that was a lot of places to go to. So for St. Augustine's program, I'm trying to even remember my level 1 internships. My level 1 internships were like when you kind of were doing more observing than you were doing clinical care type stuff. So I know I had to go to UF Shands, and I was at the acute care section and the burn unit. I did some hours at a hand center for level 1. Level 2 is like where you really got the meat and potatoes, because you were there for like, I think 12 weeks. So the first one I went to was in Virginia, which was Sheltering Arms, which was inpatient. And then the other one was Curtis Hand Center, which is one of the reasons I even became a therapist in the first place, was because my brother had a really bad car accident, and he had to have his hand reattached. My other sibling, my middle brother, also had a hand injury. He had a ring avulsion, and he ended up having a ray resection done, where they had to take out the metacarpal and push his fingers closer together. Afterward, they had initially reattached his finger, but it was basically failing. Wow. So they ended up just taking the whole finger off. And that happened while he was in the military. So long story short, I chose that particular place because I knew it was going to be an excellent experience, because it was going to bring it full circle for me in terms of seeing the stuff that I wanted to. And I actually got to observe similar surgeries to the ones that my brothers had to receive. So I got to observe an actual ray resection. I actually got to observe, you know, what happens in the amputation, what happens in, you know, reattachment. Reattachment surgeries are long, because you have to deal with not just the musculoskeletal stuff, but you're having to deal with nerve and artery involvement. So, you know, you might want a chair because they're going to be long. That internship was my favorite, because that's one of the reasons why I really became interested in therapy, because I thought it was kind of cool watching the hand therapy stuff. I had to take a test to even get to that internship.
Really?
Yeah. You had to read a bunch of articles, and your CI gave you a packet before they would even take before they even would take you. You had to take this pre-test, and they had to interview you. So you had to be like up to par before they would take you on. I scored 100 on a pre-test as a student. So I was able to take the internship on. My CI, who I loved her husband was a PT and she's an OT. The two of them actually own a practice now, not that far away from where I live, up this way, over in Frederick. But I mean, she taught me lots of stuff. In this particular location, I had to know my stuff because they wrote textbooks. You don't think I read that entire textbook before I started that internship? That's why I scored 100. Not only because I was interested in it, but because like I read all of that stuff, like even when I was in therapy school. Yeah. So she specialized in like tendon transfers. And her husband wrote a chapter on lateral epicondylitis. So you best believe I read every last one of those before I even started my internship. We had like weekly meetings where I would sit with either the physicians or the fellow therapists, and they would do presentations. So it started off that way, but because in all honesty, it was kind of like boring. My CI could tell that it was too basic for me. Yeah. So they stopped doing it like after like the first 3 or 4 weeks. And she kind of reversed it that I had to do presentations on like more complex cases, because like when I tell you I studied all of that stuff as if I was already a therapist, like I studied it to a point that when they did the presentations, I'm like, I kind of already knew it. And plus I already tested out at the test before I started the internship. Right. So I actually got to learn a lot more advanced stuff than the average student probably did. And our school, the first institution, University of St. Augustine, they were very strong orthopedic based, which is not necessarily typical for an OT program. A lot of OT programs tend to be, I'm going to say, neurological and pediatric based if you look at the curriculum. So it was a little bit out of the ordinary to be able to have that strong of a background. Because even splinting, for instance, we had an entire class on splinting, but a lot of other students that, I kind of find out after I have been out of school and working, a lot of other students, either they didn't really have a splinting class or they only learned how to make like one or two of them. And it was like on their internship. So I kind of already was at an advantage because I was already taught that stuff before I even started my internship process. I did take a job working for the MedStar network, which is what part of Curtis Hand Center is. So I worked doing hand therapy for them after I came out of school. So talk about full circle.
Wow. Now,
I just thought about the fact I didn't mention any of the ones that I went on for Howard because it's two different schools. Howard's internships. Where did I go for Howard? One of them was subacute. And what was the other one that I went on? This is bad. I'm like, has it been that long ago?
It's been a while.
Yeah, I'm like, I know I did subacute for one. And what was the other one that I did? I know I did outpatient. It was outpatient. Oh, yeah. The company that I work for now, I interned with them. So I'm like, where was I working? Oh, my God. And it was kind of the same thing. I was already in OT. I had been kind of out of, school and then came back to school. So the internship that I had taken for outpatient, I kind of was advanced before I should have been because, the tabs that are like performing as an entry-level therapist, like I was performing that like on my level ones. So, because I was a therapist, like I should have, I should match that.
Right.
So the experience was different for me only because I had to challenge myself more than other students did because technically I was ahead from taking other coursework. So, it was interesting and cool for me because I always challenge myself like outside of, going to school anyway, because I like learning new stuff. You'll always see me doing something, whether it's, if I want to learn how to paint something or I want to learn how to cook something, like that's just how my nature is. I'm a constant learner. You're not somebody that's not a constant learner if you don't major in two different types of therapy and like not be somebody that wants to learn stuff on a regular basis or, that likes to explore things. So I know I talked you to death, but I had to think, I was like, I had a lot of internships. So it's like I did like 6 of them that I had to think about.
So working in both fields, how would you define OT and how would you define PT?
So usually if I have a patient ask me that same question, I usually give them kind of like a case study, so to speak, and describe the differences. So if I had somebody that had a stroke, if I'm a physical therapist, I'm looking at that person's function in terms of their ability to transfer, their ability to ambulate, their strength, whether it's their core or lower extremity. Just because it's a PT doesn't mean that they can't work on their upper extremity, but it tends to focus more on lower quarter stuff. For the OT side of things, you're looking at function in terms of their ability to do their ADLs. So can they dress themselves? Can they toilet themselves? How can they use their upper quarter in a functional movement pattern to be able to get food off of the shelf, to be able to retrieve their clothing? So the two mesh together very well. Right. But their differences is functional OT in terms of being able to do your day-to-day stuff versus PT is focusing more on your motoric involvement for it. For me as a clinician, I think the benefit is because I have both of those in my head, when I naturally am looking at the patient, I'm looking at them from a functional standpoint, not just from their mobility, but what they're able to do in terms of function. Not that a PT can't be functional, because obviously ambulating is something functional that you have to do. But I think I can dig a little bit deeper in terms of making their therapeutic activities something more patient-centered. And I think you get better results if you think that way. and there are plenty of functional PTs that I've worked with that are able to do that. But having a background in OT helps a lot in terms of being able to access that a little bit more easily.
Yeah. And taking continuing education courses, when they talk about documentation, from my perspective as a PT, they tend to always want to say, remember, make your goals functional. So what do you think the breakdown of miscommunication is in PT programs, that you're having to reteach this over and over again, that your goals need to be functional? Why aren't they already making these functional goals and applying them as they should?
I think part of it is how they're taught and what the principles of PT kind of are based on. Because a lot of the PT stuff is more biomechanical, and a lot of PTs versus OTs tend to have different personality traits. Not that you can't have the same personality traits, but PTs tend to be people that are like problem solvers, mechanical type of brains. So I think a lot of people just kind of think of like the rote numbers and things and then leave out the function. So you're thinking about, somebody getting 120 degrees of knee flexion, but okay, what's the point of getting it? Are you trying to get that amount of knee flexion so that they can go up a set of steps? Are you trying to increase that amount of knee flexion so that they can go into swing phase during our ambulation? So I think some of it gets missed because they're focused so much on the mechanics of how things work rather than the function that you're trying to carry it into.
All right. And with OT too, you guys have more of a cognitive component to it as well, right?
Mm-hmm.
All right. Could you elaborate on that a little bit, how that works?
With the cognitive portion of it, that carries a lot into that person's function as well. I might not have to do cognitive stuff with every patient that I have, but I am going to have that on the radar for people, in particular my neurological patients. Because if you're not able to connect some of those things that I'm trying to explain to you, I have to be able to break it down so that I can figure out how to make something solvable for you, so to speak. So if I have somebody that had a CVA where they have visual perceptual issues, I need to problem solve through that so I can figure out what I need to do to make something accomplishable for them so that they can be more independent. So you do have to know a little more like visual motor type of things, cognitive things, their perceptual awareness, so that you can make things resolvable for them. Sometimes people are able to be, quote unquote, rehabbed. And sometimes people, you might have to do compensatory techniques because it might be something that is a permanent issue. Like say for vision, for instance, say that's something that somebody is not able to reverse. You might have to do compensatory techniques so that you can help that person figure out how to navigate it, whether it's, how to scan their environment or using different color coding systems so that person knows where something is placed, or placing things in a certain clock system so that they can access their fork or their spoon when they're eating their meal. So OT, in terms of the cognitive part, it's a lot of problem solving and seeing how that person integrates some of those skills when it comes to their function.
Yeah, personally, I think as PTs, we should have had a lot more of that training too. And I've actually considered going back to school or either getting a certificate in exercise and sports psychology. So I think a lot of times we can rehab them functionally, but they don't always make that mental connection that they're ready. So I think exercise and sport psychology component of it will make for a more holistic rehab approach, but that's just
right. And some people that you're seeing in terms of the rehabilitation process on the PT end of things, especially somebody that's an athlete, there's a strong psychological component to that because you're tending to work with people that are ultra competitive, right. And sometimes their own well-being might not be the thing that's on the top of their list. They're more concerned about being able to compete. So that person might be injured, but they still want to go back out into the game, or they might be told they're going to need a hip replacement if they keep running outside, but they want to run outside anyway because it's something they enjoy. So you are having to deal with a lot of psychological stuff, because not to say that that person can't do those things anymore. One, you might have to adapt it, or two, you might have to work on a psychological component of that person so they can persevere through it, because pain has a ton of psychological stuff to it. a lot of these patients that we might have with, for instance, fibromyalgia, I mean, a lot of that is somebody that has, a lot of pain sensitivities, and that just manifests in their body so much that it affects their functions.
True.
So I very much agree with you on that in terms of the psychology of exercise and all of that.
Yeah. So let's go into your role now. What's your job title? What exactly do you do within that role?
So I am a patient care manager of an outpatient clinic here in the Baltimore area. The role that I took on was as a PT manager, but I am basically in the process of creating an OT program. I have built the caseload enough that honestly, I should be getting to a point to be able to hire either a PT to fulfill the PT patients that I have or an OT. It's probably going to be more likely to be a PT, but we're kind of, seeing where that goes. I'm also working on something called Revital, which is an oncology certification through the company that I work for. I already actively treat oncology patients. I'm certified as a lymphedema therapist. So that kind of goes hand in hand with some of our breast cancer patients. Some prostate cancer patients may have some issues with lymphedema, but that usually involves more of like wrapping and teaching them things to do for their prostate or their lower extremity. For the program that I'm working on in the clinic that I'm in, I'm basically building the hand therapy and the oncology programs. With being in the middle of a pandemic, of course, it's a little more difficult. But the irony is that the clinic has been performing actually better than it did the year before when it wasn't a pandemic since I've been there. Thank you. So part of it is critical thinking in terms of figuring out how to get people into your door. A lot of outpatient clinics rely on post-operative referrals. Obviously, in the middle of a pandemic, a lot of people are not having surgeries because they tend to be elective when they're orthopedic unless somebody had an actual, injury. So I kind of looked the non-traditional route. People are not stopping having strokes. Children are another population of people that are not getting access to care because if they're in the school system, they're not in person at school. So a child with autism, child with ADHD, a child with cerebral palsy, they're not getting access to the care that they might need to be able to function for not only their scholastic stuff, but to be able to function at home. So I've had some pediatric patients that have some developmental issues or developmental delays, whether it's having trouble crawling or they have plagiocephaly or difficulty walking. Somebody that's a toe walker, the parents are spending more time at home with their kids. They might be identifying more of this stuff now. Right. So I've tapped into that market. I've tapped into the neurological market. Also, some of my patients that are amputees, and also talking with a vascular surgeon, because one of my other specialties being lymphedema is not only for oncology patients, but people with vascular insufficiencies that developed swelling in their extremities. So I built some populations off of that. So I think developing relationships not only with the physicians that are in your community, but also like marketing within your walls, so to speak, because I've had a ton of patients just from one patient that I treat. I also treat post-COVID patients. So a lot of the issues that they have are, cardiopulmonary deficits, obviously, dealing with fatigue, some abnormal responses to exercise when it comes to their heart rate and blood pressures. So you're basically kind of doing like circuit training to try to build them to that point, and you're monitoring them throughout their exercises. Mm-hmm. So if I've treated a post-COVID patient, for instance, that works in healthcare environment, well, they have other people that they know have dealt with the same thing. So I get referrals of other people that are dealing with post-COVID. The pediatric patients, well, a parent is very excited about when their child is able to do something. So right. A lot of parents have a network of other people that are raising children that have different abilities. So they're going to also market for you, even when you're not, there in person. For some of the patients that I have that are dealing with swelling, I typically in their chart, I take pictures of their befores and afters. And I ask for permission. And I send that to their physicians. And that also, matriculates a little more referrals as well, because they're able to see a difference. Some patients might have had swelling in their legs for a year, 2 years, and not able to find relief. So a lot of those specialty things that I do, I try to be innovative so that I can access the community of people that are usually not able to get that help, because a lot of outpatient places are focused a lot on just general orthopedic patients. And there are some people that are in the market that are not getting that care. So that's one of the things that I take pride in, because that's what I had to do for some of my family members, like my mother, for instance. Some of her wound care issues that she had, she was somebody that had breast cancer. So looking at some of the issues that she had to deal with fatigue and all of that. So a lot of the things that I do in my career, like my heart is in it, because I'm, imagining people that I've been able to help in my family, or somebody that I couldn't, completely help, so to speak. It propels me even further. Something that I may or may not have been able to do for my mom, I'm able to do for another person in their family, of people that are survivors. So I just thank God for that motivation, because despite some of the barriers that I may have had to get to the point of being a clinician, the joy that I see from my patients that are getting better, that's what helps propel me every day. Because there might be times where I'm tired, or I don't want to come to work that day, or I'm in the middle of a pandemic and maybe income isn't the same, or I can't go out and get stress relief, or I can't go to the gym. There's a lot of things that we're limited in being able to do right now.
Right.
So I thank God for that perseverance to be able to continue to work for the people that need it the most.
Yeah. So you mentioned everything you do on the job, but you also do a lot of things outside of therapy. You mind touching on those?
So because I am crazy, because apparently going to work is not enough. I'm also an entrepreneur. I'm a creative entrepreneur. The entire time that I was in therapy school, I would cook and bake, especially when I was at St. Augustine. So I would have like little dinner parties, and they were just excellent stress relievers for me to be able to bond with other people.
I do remember those parties. Those were great.
So, food is something that we do a lot in celebration of things, it's an opportunity to, break the ice with people. So I very much enjoy doing that. I'm not only somebody that enjoys cooking, but I also like to bake. So one of the things that I do is custom cakes. I'm working on writing a cookbook. That's going to take a while, especially in the middle of a pandemic, but that's something that I have in the works to be able to do. And I also do some graphic art stuff. I am working on trying to turn that into another stream of income. Eventually, I would love to be able to have children in the future. I haven't quite, met that goal yet, but I feel like, especially as a minority, it's very important to be able to figure out streams of income that you can have, not just from, your therapy career while you're working, but when you get into retirement, there are a lot of things that can happen in terms of your income stream, because the cost of living is not going to stay consistent.
True.
So a lot of the times what you think you're going to be able to do into retirement, you might not be able to because you don't have the income to do so. So I generally always try to have 2 or 3 income streams. Right now, being in the middle of times of COVID, I haven't really been able to do a lot of custom cakes because people are having much smaller events, of course. So I had to think outside of the box. So I also teach classes online, or I might do a Zoom event or host a group on Facebook that has some of my recipes in it and teach somebody how to do a recipe. So a lot of it is I have to channel my energy into other things, not just in the work environment, but I'm naturally somebody that always wants to learn and do something. So that's what I do outside of work as a crazy individual. doing a lot of extra artistic things. I paint, I draw, I decorate cakes and cook and a lot of other things. So I think that's also how I try to manage stress as well, because if you don't seek out some of those external things, a job like this would really be difficult to handle, because especially if you're treating more medically complex patients, you internalize a lot of their issues that they are having, because if you're a person that has any empathy, you're going to be thinking about those people when you're outside of work. You can't turn that on and off. Mm-hmm. So if I have an oncology patient that's not doing well and they're at their end stage of care, I'm going to internalize that because they're like part of my family. So I have to have other things so I can kind of like get that off of my chest. My mom had breast cancer and she passed away of a cardiac arrest shortly after she was cleared of her cancer. So it's very, knew it was going to happen. So sometimes treating those patients can be difficult because it might remind me of my mom, but it also propels me to move forward, because whatever I feel like I wasn't able to do for her, I'm able to do for these patients. So yeah, that's why I do what I do.
Well, I commend you for everything you do and just persevering through all of it too.
Thank you.
Where do you see both professions going?
So I have this idea in my mind that it might not even be something therapy related, because I love doing things outside of work for people. I would love to be able to like start a program or a nonprofit organization or something that I can do for people outside of a therapy realm, whether it's an adaptive sports or something. My brain is still stewing on that. But that's something that I see myself doing in the future, whether it's hosting classes for people. I usually say differing abilities. I mean, disability is a word, but a lot of times I just don't like that term in terms of making it feel like somebody has a limitation, because especially with the children that I work with, for instance, there's so much that they are able to do. So I usually say differing ability. And I would love to be able to do something with that. I'm still letting my brain turn. I have started writing a course for like fine motor skills and like cookie decorating, for instance. That's something that I've done with some of the patients that I have in the clinic now. It works on a lot of stuff in terms of intrinsic hand strength, eye-hand coordination. So basically combining some of the stuff that I like to do outside of work with my actual job. So that's where I see myself sometime in the distant future, is figuring out how I'm going to mesh those things and create some sort of program or something external that I can do outside of work.
I like that. Now, from what I've noticed, you are a pretty good patient advocate as well. Have you noticed differences in how other professions, or even within our professions, how they advocate for different types of people or different races of people?
So part of my advocacy with patients is because of my background from my undergrad with the rehab counseling. Before I went on to therapy school, I had about a year of time that I worked doing case management and job coaching for young adults with disabilities. I also had done a period of time being their advocate for their IEPs. So transitioning from school to the workforce. So I think that comes into play in terms of being a little bit more of an advocate. In terms of disparities, you very much see that in healthcare. You very much see that in healthcare, especially minorities. So I like to take those opportunities as a clinician that is a minority to educate the patients that are coming in my doors. It doesn't matter, the color of someone's skin that comes to see me in the clinic. But at the same time, there is something that's different of being a minority and having other patients that are minorities. They bond with you in a different way, possibly because they may not have seen a clinician that looks like them before. So you might tap into them a little differently than others may. I have worked in places, obviously I'm not going to say the name of any of those places, but I have worked in places where I may have seen some things that I didn't think was right or correct. So obviously I'm going to say something, and I do say something, and I don't think it's right for somebody to have access to something that somebody else, doesn't have access to. Whether it's a certain service that's available to them, or whether it's a placement that they think is appropriate when somebody's being discharged from a certain facility. And it's difficult being in this position in terms of not internalizing it, but still being able to help people at the same time. Because you do have to have a little bit of a separation so that it doesn't become too personal. But it's always going to be something that I take to heart when I'm working with people. I had a patient that she was actually not a pleasant person when I met her in a subacute environment. And she was actually admitted because of a suicide attempt. She was very rough around the edges, but I think the problem was people were not tapping into what her bottom line issue was. So the staff was very unpleasant to her in return. And I stood up for her because the nurse that was working with her, some of the things that were coming out of her mouth, whether she was saying it directly to the patient or outside of her door, I didn't think was right. So I went to the unit manager, and she was no longer her nurse after that. So there's a lot of things that I don't tolerate. And somebody's behaviors is not because of the color of their skin. Some of their behaviors may be because of what they are experiencing.
True.
So I'll just say that in the long and the short of that interaction of what happened. But I've seen people be called things. I've seen people being treated differently, and it didn't matter what setting that I was in. I mean, I've seen some stuff in a variety of places that I have to speak up because sometimes they're not able to speak up for themselves.
So 2 things in regards to that. One, why do you think some people are afraid to speak up for their patients? And then 2 is, what could we do to kind of better facilitate re-educating individuals on these disparities?
I think part of it may be that person might be afraid they're going to lose their job, or they're afraid of what they're going to get in terms of their employer, even if they stay at that job, some of the backlash that they might get from it. And some people, it might just be a personality thing. Like, I'm much more vocal. Other people that might be shy, they might not feel comfortable in that situation, so they don't speak up. I'm kind of like an ambivert. So I'm very vocal when it comes to work-related stuff, but in my personal life, people think I'm quiet. I'm actually not. I'm just really vocal about things I'm passionate about. So you just got to talk to me about the right things, and then you're going to hear me talk. Did I miss a secondary question? You had something else?
How we re-educate clinicians on these disparities and standing up and advocating for patients.
I do it on a regular in my job, and also when I take students. Whenever I've taken a student, because I'm looking at things on both ends of the spectrum as a PT and as an OT. The old school stuff that you learned your first, year of school, that person's impairments and their social participation and all that kind of stuff. So I usually break that down with not just my students, but sometimes with a staff member I might have in terms of why somebody might not be doing the best. And disparities don't have to be about color either, or somebody's race or gender. Sometimes it could just be their social environment and their economic status. So I've had patients in the past where they might not have access to a wheelchair or equipment that they might need. So one thing that I've done since I've been working the current position that I'm in, it's a little bit rough because I'm in a new area. So I moved to a new area in the middle of the pandemic, and I don't really know the resources as well. So I basically kind of created like a little resource book for myself. So vendors that have wheelchairs, somebody that's an assistive technology provider, a prosthetist, orthotist, mobility services. So I tried to get access to all of that stuff so that I kind of had a little binder that I could refer to for patients that might be having more of a struggle. And there's one particular gentleman that's an assistive technology provider that obviously he has a good heart as well. I had a patient that is an amputee that didn't have an adequate wheelchair. I didn't think it was safe because the brakes wouldn't lock. And I tried to fix the brakes myself, and it's not something that was fixable. They went to that person's business. He saw that it wasn't fixable, and he replaced the chair for her of no cost to her.
Wow.
So for her, with Medicare, if you've had a wheelchair within X amount of time, you're not going to qualify for another one. So she was in a time frame that she wasn't eligible for another one. And there are some other things that were going on in her history that made it a little more difficult in terms of being able to get around in her house. So building those connections with people in your community is a tremendous way that you can try to pull people out of the disparities that they have, because sometimes they might not have social supports at home. Or if they have social support at home, they might still have economic struggles. Mm-hmm. So I usually try to look at all of those things and figure out a plan, whether I'm directly able to help the person or if I find somebody else as a resource that can do the same thing. So that's something as a new clinician or existing clinician, I strongly recommend people doing. Of course, it takes a little extra time to go out and do those things. But at the same time, from a business standpoint, if you're somebody that owns your own practice or you manage a practice or you work for a practice, that brings people to your door too.
Right.
Because the connections that you've made with those people in the community, well, they're going to know of a therapist that's in your area, because if I've already been at that person's door for their services, well, they remember me. So it's kind of, like a double-edged sword. There's ways to tap into those disparities, and there's also ways to find solutions for them.
True. Now, before we get off today, I don't want to take too much of your time, but are you open to mentoring?
Sure. I mean, I feel like I kind of already do it. So.
And then how can we find you on social media?
So I have more than one social media account. You're probably not going to want to follow my cake account if you want mentoring regarding therapy stuff. But probably my Once Upon a Hines account, which is more of a personal account. People can follow me there. I go by Aimee J on most of my social media. Johnson was my maiden name. Hines is my married name. But Aimee J is something my grandmother and my mother used to call me. So that's why I go by Aimee J on a lot of stuff. So that is how people will probably be able to find me.
All right. And spell that for us, please.
The Once Upon a Hines?
Yes.
Look, my brain cells. I'm like, wait a minute. ONCEUPONHINES.
All right.
And my name is spelled differently. So if people are looking for my name, it's AIMEE. And if you're looking for Aimee J, it's JAY.
All right. Thank you, Dr. Aimee, for joining me today. And thank you guys for tuning in to the 5% PT podcast. We'll see you next episode.